Roger, we're really pleased you can come and be with us for today, and we look forward to what you're going to share with us. Thank you.
Thank you. I'm hoping these microphones will be loud enough. Thank you. Can everybody hear me okay? With the slides, I will gradually introduce myself. I'm a GP, and I'm also the medical advisor to the URC, and I'm also a non-stipendiary minister in the URC. I thought the reading chosen this morning, I'm going completely off piece to begin with from my slides. Indeed, the body does not consist of one member, but of many. And actually, for me as a doctor, the most important organ in the body is actually the brain. And when it starts to fail, then sadly, dementia results. And I think it's very poignant with everyone gathered, because you're obviously wanting to find out more information about this really difficult subject. If one member suffers, all suffers together with it. If one member is honoured, all rejoice together with it. And I thought how poignant as well. I know the hymn that we sang is based on Psalm 103, but it just seems so relevant to people who suffer with dementia, people who look after people with dementia, carers. And, you know, we sing this so often, and yet it's so poignant. Frail as summer's flower we flourish, blows the wind and it is gone. It's probably very poignant for me too, because I actually lost 2 patients yesterday with dementia, or at least they were patients who died who had dementia, and that was probably what led to their deaths. The talk that I'm going to do now is actually very didactic, so I'm probably going to be talking at you in true biomedical mode, because I'm thinking you're wanting to have some factual information about dementia, and that's what I'm going to deliver with these slides. So I'm going to be using the dreaded PowerPoint. I hate PowerPoint. I don't usually use PowerPoint. But when you come to the workshop this afternoon, there will be no PowerPoint, and it is going to be a true workshop where you are going to do a lot of the work, and I'm going to facilitate it and hopefully share your expertise. So that's the plan this afternoon. The other thing is just to say some of what I will be going through this morning will be personal to you for lots of different reasons, and I apologise if it touches a difficult nerve or memory or experience in your life. I can only apologise for that, but obviously very happy to talk through that as the day progresses. So it's not a heavily academic talk that I'm doing. It's about dementia, what is an incredibly common problem, and I'm going to give you some statistics about that. It's very much from a medical perspective rather than my perspective as a minister, but I will touch on the spiritual side towards the end of this talk. I said I was going to introduce myself, so I'm going to tell you a bit more about myself. A few pictures. I'm a GP in a little village called Hampton in Arden, where I've been since the 1st of June 1995. It's where Shakespeare is supposed to have written his play As You Like It. It's next to the NEC, Birmingham International Airport. It was there before Birmingham International Airport. That's a picture of my GP surgery, which I went there as a single-handed GP originally. It's had several extensions done, so it doesn't actually look like it does in that picture at the moment. But that's with one of the latest extensions. On the other side of the car park is the village hall. So one of my other hats is that I do postgraduate vocational training, so for GPs in training. So I run postgraduate vocational training scheme, which just happens to be in the village hall, which is a really nice location overlooking the fields of Warwickshire. But I'm also responsible for undergraduate GP training, hopefully inspiring the next generation to become GPs at Leicester Medical School. Apparently there are other sporting activities going on this morning, but you will know that Leicester is the home of Premiership football, the best football team, not just in the land, but globally. There's something about 9-0 the other day, I remember.
I'm a Saints supporter.
Oh, right. Oh, dear. Right. Better move on from that.
That's the wrong version.
This is where I spend a lot of my life, the consulting room. Sometimes that consulting room is transported to people's homes, but most things happen in the consulting room. That is not my consulting room. That's the consulting room on the Isle of Jura. For everybody that knows where the Isle... Does everybody know where the Isle of Jura is? Because it's to the west of Glasgow. You've got Arran, the big leg that comes down, the Mull of Kintyre. You move over to Islay, which has about 12 or 13 distilleries on it. And north of it is the Isle of Jura. Now, why on earth am I telling you about that? I've just returned from there. I do locums on the Isle of Jura. So I do lots of different types of general practice. But I just wanted to show you a typical consulting room. That's where, when I wear my URC hat on, that's where I tend to do most of my preaching, which is at Knoll URC within Solihull. So they regularly ask me to take services. I do go to other churches as well, but it tends to be Knoll URC. I have the difficulty that I actually worship in an Anglican church because my wife is, she's not here, well, she was here earlier, she is Anglican and I still can't cope with liturgy, but anyway. But that's because our village literally has, well, it has two churches in it because it has a Coptic church as well. Now, this for me, I'm going to tell you a little bit what I talk to students. One of the patient expectations of us, so if you imagine a patient with dementia or their carers, they expect us as a GP to be their doctor, to accompany them on the journey, to follow them up where cure is not possible, and at the moment dementia can't be cured, to be available for them, to be there for them. But the key bit of being a GP is communication, and hopefully also to be compassionate in, if I dare say it, the very toxic atmosphere of the NHS, because it's a very difficult organisation to work in. But I'll try and not digress down that road, I'm sure. So one of the things that I often say to students is to remember that there's a difference between illness and disease, and then they think I'm completely mad because surely the two are the same thing. And actually, if you think of any disease, and I'm thinking particularly obviously of dementia, there's the disease process, but it's how it actually manifests itself as an illness, and that will be different and unique to each individual. So if somebody has Alzheimer's disease, it will be different in every individual that has it. That illness manifests itself differently as a disease. I've got this rather simplistic diagram of where I've put disease and illness, where there's an overlap between it, because for us as GPs, we see a lot of people who are ill, but there's no identifiable disease. Probably about half of the people we see come in to see us with all sorts of different problems, but there's no identifiable disease. But when they get ill, it affects them psychologically, their personality, their emotions, their attitudes. It affects them spiritually, it affects them as a person. So if you imagine somebody with a disease of dementia, that's how illness is going to manifest itself. And people often forget about that. They think about the biomedical, what's the pathological process that's going on to cause dementia. In some ways that's not so important. What is important is how it affects them and their family. Outside the box is what I call life, personality and spirituality, and I presented this once at a conference in Paris, and somebody got up and said, you mustn't have a solid line around the box. And I know I'm preaching to the converted, but they said, what about the existential? What about that outside of the physical, the psychological. So that's why there's a dotted line around the box. I presented that at a humanities conference in Paris, and they got very, very excited about this. And also they don't use PowerPoint, so I presented it using a whiteboard. So in a sense, I've answered this question, what is general practice? General practice is much more than the physical. And also for us as GPs, and you're going to hear colleagues speaking later on, it's not just about us as GPs. We work very much as a team. We have different people within the team with different expertise. But one of our roles as GPs, and thinking of people with dementia, is helping patients and carers to navigate, to be their advocate, to navigate what is a very complex system, the NHS. Partly telling you about Scotland is different in Scotland than it's different in England. It's different in Solihull to what it is in Cambridge. So one of our jobs as GPs is to help people get through the maze, which is very, very difficult, of the NHS. The other thing to remind everybody of, and I keep doing this as a medical teacher, is to try and tell students when they start medicine, medicine is not an exact science. They go into it thinking it's an exact science. They do chemistry, biology, and all physics and all the different things. Medicine is not, and probably never will be, an exact science. It is an art aided by the application of several sciences in which philosophy, religion, and sometimes commercialism also play a part. You'll notice the commercialism, thinking what's happening in relation to the NHS, is the NHS for sale at the moment. This was written in 1930. So things actually haven't changed in relation to the NHS. Why am I telling you about medicine is not an exact science? If you think of a Boeing 767 engine, if something goes wrong with that, every Boeing 767 engine is the same. They are straightforward to fix. There's a dial, there's something that will show up an error with that engine, but that is not so for a patient with any disease, including dementia. How to help them, how to put them in right, in inverted commas, it's not an engineering problem. And that's what makes all of our jobs and medicine so challenging, and perhaps most so with somebody who has dementia. Medicine is not an exact science. This is just a sort of rest slide for me. This is the sunrise at Nottingham University campus where I used to be until quite recently. So, huge challenges ahead thinking in relation to dementia. It's time for some facts and figures. UK population is projected to increase by 9.6 million over the next 25 years. The number of people aged 80 and over in the UK is projected to more than double to 6 million by the middle of 2037. The frail elderly population, if we can define people as such, they will be a transition from 90-year-olds to people perhaps in the region of 110. That's what's being thought of at the moment. Current life expectancy in the UK, a male is 79, a female is 83. That is expected to increase. Dementia, now this is the key bit. 2014, 1 in 79 people in the UK population have dementia. That's huge. It's absolutely huge if you think about it. And an increase by 156% by about 2050. So dementia is a huge, huge issue in life, in healthcare, more so in westernized countries because people live longer. According to the Alzheimer's Society, there are nearly 1 million people in the UK with dementia. Just think about that for a minute. That's an awful lot of people. 1 in 14 people over 65 will develop dementia, 1 in 6 people over the age of 80. So we said how the frail elderly population is going to increase in proportion. That's an awful lot of people. That's a huge, huge issue. Anybody know where that picture's taken?
Oh, yes.
Please tell me.
Coventry.
Yes. That's Coventry Cathedral, or the old Coventry Cathedral, ruins. They do some amazing plays and all sorts of things there. Obviously, I live quite close to Coventry. In fact, my wife sings in the Coventry Choral Union. That's the same slide I showed you a minute ago. What are patient expectations of us as doctors? The same apply to you as a minister, I think. I think that would be true to say. If you have somebody that's ill in your congregation, to accompany them on the journey, to follow them up when cure is not possible, to be available, to be there for them, to communicate, to be compassionate. There's no difference between a doctor, if I can use the phrase, and a priest. They're the same, if you think about it. The only difference is I've got medical knowledge which occasionally I can use to apply to the disease process. But if you think about dementia, and I'm going to come on to that in a minute, there isn't actually, I don't have a lot of armoury as a medic to help patients with dementia, but this is the bit that is more important than anything. What happens in the consulting room? That could happen, you could be on a pastoral visit, it could be a conversation after church, it could be a conversation in the church, you might see somebody on their own at the church, relatives. Just to tell you what the motto of the Royal College of General Practitioners is, Cum Scientia Caritas, which means scientific care, scientific skill with loving kindness. The bit that medical training knocks out of students is the last bit, loving kindness. My area of research at the moment is compassion. I'm writing lots of papers on compassion. I mentioned the toxic atmosphere of the NHS. It's a really difficult organisation to work in, particularly for junior doctors going into it, because they don't have time to apply the last bit, loving kindness. If you've got somebody with dementia, a family with dementia, that bit is more important than anything. Scientific skill, as I've tried to intimate to you at the moment, is pretty limited in relation to dementia. I took some slides off NHS UK to try and give a little bit of objectiveness to what I'm saying, because I'm not an expert in dementia. So let's just think about some of the symptoms and signs that people will get. If you're becoming increasingly forgetful, particularly if you're over the age of 65, it may be a good idea to talk to your GP about the early signs of dementia. Often it's a matter of reassurance, because as people get older, we all find memory loss is an issue. And the key bit to say to people, if you're already worried, is it is normal for your memory to be affected by stress, tiredness, or certain illnesses and medications. It does not mean that you have dementia. So that might reassure people in the room who are worrying. I have a lot of people come to see me as a GP that are worried that they've got dementia. And I'll show you, there's a screening tool that you can use to ascertain whether they really do have a memory problem or not. But dementia isn't just about memory loss. It can affect the way you speak, think, feel, and behave. It's much more than what it does to memory. And it's also important to remember that dementia is a disease. It's not a natural part of aging. So it's not normal to develop dementia. It's just that it's commoner as people get older. Forgetfulness, yes, this can be annoying if it happens occasionally, but if it's affecting your daily life or is worrying you or someone you know, then that's the time to seek help. So what is dementia? Dementia is a syndrome. That's a great word that doctors use. If you've got a syndrome, it's usually doctors don't actually know what's wrong with you. But it's associated with ongoing decline of brain functioning, cognition. Cognition is thinking. Cognition is also all the things below: memory loss, the speed at which you can think, how sharp you are mentally, language, understanding, judgment, mood, movement, difficulties carrying out daily activities. So it's collection of all of those things are affected when somebody has dementia, and particularly advanced dementia. An early sign may be issues about memory. Now, there are different types of dementia. I'm very happy if anybody wants these slides afterwards. You're happy to, just to save it, people writing things down. You're very welcome to have these. I'll leave them on the laptop. So people get confused about the difference between Alzheimer's disease and dementia. I was checking this presentation with one or two of my colleagues in practice yesterday. Alzheimer's disease, we use that term very globally. Technically, you can only make the diagnosis at post-mortem or by taking a biopsy of the brain, which isn't a good thing to do. There's debate as to whether you can technically diagnose dementia from a scan, and I think the feeling is that you can, but you can't be sure it's Alzheimer's disease, because if you look down a microscope at brain tissue, that's how you actually make the diagnosis. So it's a diagnosis of exclusion. But Alzheimer's disease is a type of dementia, but together with vascular dementia makes up the majority of cases of dementia. In my experience, and this is trying to give you a bit of subjectivity to objectivity, Alzheimer's is different because it's rapid and it affects physical function. Now, when I mean physical function, I mean all sorts of things: ability to walk, talk, go to the toilet, feed yourself, get dressed. Whereas vascular dementia, that's where the vessels going into your brain are getting blocked up with what we call atherosclerosis, which is due to cholesterol. And it's a very, very gradual process, and it affects mainly memory. It doesn't usually affect physical function unless other blood vessels in other parts of the body are getting blocked off, and the classic place is the feet and the heart. And it usually happens in people who have got an awful family history of high cholesterol, or people that smoke or do both. They are very, very at risk of vascular dementia. It also has a stepwise decline, unlike Alzheimer's. So they're sort of okay, and then they take a big like trip on the steps, they go down. It isn't a gradual decline, it's a sort of stepwise decline, if that makes sense. I was just trying to give you an idea of the difference between Alzheimer's and vascular dementia. They're both very, very common. The vascular dementia is also, we used to use this awful phrase called senile dementia. That's probably more what vascular dementia is. It's much commoner as people get older, because as you get older, your blood pressure and your cholesterol continue to rise. So everybody is at risk of getting vascular dementia. But without going on a doctor hobby horse, if you smoke, it's much more likely to happen much more quickly. People with dementia can become apathetic or uninterested in their usual activities, or may have problems controlling their emotions. They also find social situations challenging and often lose interest in socializing. Now, this is a key bit of dementia. Aspects of their personality may change. A person with dementia may lose empathy, understanding and compassion. They may also suffer with hallucinations. Now, the other thing about dementia, I've had a patient commit suicide with dementia, somebody who had enough insight early on in their dementia to know what was happening to them and made the choice that they didn't wish to carry on living. I didn't know they'd made that choice. I'm just saying that that sometimes happen. And there's this person called Rob Williams. I don't know if anybody's heard of him. Robin Williams, who's a famous actor. Yeah. He had something called Lewy body dementia, which is incredibly rare. Which I'm happy to talk about the details of later, but he actually took his own life as well. So it's an important thing to remember in the early stage of dementia. People do suffer also with depression, and they are actually at risk of suicide, and we may not realise that. Just a break. I won't ask you where this slide is. Anybody know where this slide is of? You've probably already given it away partially, but that is Coventry as well. There's this lovely couple of chairs walking from the station towards the cathedral, and that's in the snow. Coventry's sort of regenerating itself as a city. So people with dementia may lose ability to remember events or fully understand their environment or situations. It can seem as if they're not telling the truth or are willfully ignoring problems. That's obviously not the case. But you may not realise that in somebody with early dementia. As dementia affects a person's mental abilities, they may find planning and organising difficult. Maintaining their independence may become a problem. Now that last bit that I've underlined, you will come across people who say, I do not have a problem, go away, I do not want any help. They know they've got a problem, but because they've still got what we call mental capacity, they can make that decision themselves, and there's nothing that we can do about it. And I've got somebody at the moment with the relatives. Something has got to be done, but that person does not want something to be done. They have got enough insight. They want to stay independent. And that's a huge challenge in relation to dementia. Usually somebody with dementia will seek help from friends or relatives and also ask for help with decision making. Why is it important to get a diagnosis? Even though there's no cure for dementia, and colleagues later are going to say why it's so important to get a diagnosis, there is medication, there is some evidence that it slows down the progress of dementia, but it can help get the support services into place, and there are a lot of support services for people with dementia. The other bit that's absolutely key is people may want to write a living will, sometimes called an advance directive. They may want to put lasting power of attorney into process. They can only do that whilst they've got mental capacity. Once they haven't got mental capacity, these documents don't have any legal validity. And it may be that they ask for things, I don't wish to be hospitalised, I don't wish to have antibiotics, etc. But they can only do that whilst they've got mental capacity. So one of the things is allowing them time to prepare for somebody who does want to be helped and knows that they're the situation that they're in. It's important to allow them to continue to lead an active life, and I think one of the themes of today is to talk about church-friendly worship for people with dementia, so those people can carry on worshipping and lead a normal life. Unfortunately, dementia will worsen with time, and in the later stages people will be able to do far less for themselves and may lose much of their ability to communicate. So how is the diagnosis made? This is the most important thing. There are lots of these, some of them are short, some of them are longer, memory screening tools. So you'll know you've got a problem with dementia if the doctor starts to ask you to count back from 100, taking 7 away, or who's the Prime Minister, or do you know what time your appointment was today? And if the person who's on the ball say, yes, it was half an hour ago and you're running 30 minutes late.
Excuse me, people over 65 tend to be asked that anyway.
I hope not.
I know somebody.
Oh, right. But there are many of these tools. This is called the 6CIT tool, which is probably about the quickest to use. So memory assessment, we usually take blood tests because there are 1 or 2 causes of dementia that are reversible, like vitamin B12 deficiency, pernicious anemia. The other bit that will inevitably happen is that the people will have a scan. There's a debate as to whether it's better to do a CT scan, which is with X-ray, or an MRI scan, which is with magnetic resonance. If you have the choice, have the magnetic resonance one, not because it's more uncomfortable with the noise, it's because you're not exposed to radiation. So what you're looking for is evidence of ischemia. Ischemia means the brain has lost part of its blood supply and has basically died. So that's what happens in a stroke, but that can also happen in dementia. So the bit that's to do with your memory, you could lose the blood supply to. So you can see those ischemic changes on scan. The other bit, and that's how we usually diagnose Alzheimer's now, is cerebral atrophy. So atrophy means that something is not of the same quality that it was when it was new. So if you imagine a vegetable like a carrot or something, or a potato, if you leave it for a while, it'll start to atrophy in the cupboard. It'll get smaller in size, it won't look pristine like it used to. That's probably the best way of describing what atrophy is. So cerebral atrophy means that that's what's happening to the brain. And that's what happens in dementia, classically in Alzheimer's dementia. Ischemia is what happens in vascular dementia. And to a certain extent, they're equally common. It depends on the population that you're living in. If you're living in a population, a deprived population where people probably smoke and drink more, they're more likely to suffer with vascular dementia, if that makes, that's why I'm it depends on the population. Need to exclude treatable causes. As I say, unfortunately, they're quite rare. If it's vascular, smoking cessation is absolutely vital, and it's advice which is never well received. My father-in-law died with vascular dementia, and he was an insistent chain smoker, and he would not stop smoking. And it was very sad because he died at a relatively young age, and that was purely due to smoking. So smoking cessation is absolutely vital. So what of treatment? We've talked about making the diagnosis, planning care and support, I'm going to talk about later, but it's always important to put people in touch with Alzheimer's Society. They're an incredible resource. Volunteers will differ according to where you're located. One of the greatest volunteers are where there's a setup where people will come and sit and give what I call the informal care of the loved one, because looking after dementia is 24 hours a day. It's really important that they get a break. So if there's a system of volunteers where the person with dementia can get, hopefully, to be familiar, get to know somebody and feel comfortable in their presence. And the Admiral nurse is a bit like the Macmillan nurse for cancer care. It's the specialist nurse. So the Admiral nurse is the sort of specialist nurse for somebody with dementia. Respite, I've sort of intimated. Carers are professional like me, and informal carers are the key ones. Those are the family members or the friend that's with that person all the time. I'm showing you pictures of trams is to make the point that guidelines are not tram lines. There are no specific guidelines for looking after somebody with dementia. So there aren't tram lines, there are only guidelines. Most of the medications available are used to treat Alzheimer's disease, which is the most common form of dementia. They may help to temporarily reduce or delay progression of symptoms. One of my colleagues said yesterday, one of the difficult decisions to make is, when do you stop this medication? Because people have this worry, well, it'll get an awful lot worse if you stop it. The answer is no, it won't, but it's an ethical decision as to when do you stop it. It is medication that's usually started by specialists, not by GPs, and it's specifically for Alzheimer's. The pharma industry will always tell you there's a new drug, and this is just on the news this week, there is a new drug about to come out. They tell you it's the wonder drug, it's going to cure dementia. I hope they're right. But remember, pharma's interest in life is to make money. This will be very expensive. Like a lot of the predecessors of medications in dementia. Let's hope they're right. I'm not trying to be cynical, that's just the way of life in medicine. I'm going to flick through these slides very quickly, is just to tell you that there are medications for dementia, and I've put them into different categories. What is interesting is the bottom bit in bold, this is about cholinesterase inhibitors, is that there is little difference between these medications and their effectiveness, and there is actually a bit of a sideline to that, is how effective are these medications anyway? And I think, in truth, they may halt the progress, but they're not desperately effective. If they were, we'd be prescribing them to everybody. This is another group of medications that can be used for dementia. There's lots of biomedical terms in this which I shan't bore you with. The other thing is, there's great debate as to whether, when somebody gets advanced dementia, particularly Alzheimer's type dementia, and they become agitated, anxious, wandering, aggressive, have delusions. There's huge debate in medicine now as to whether we are allowed to use tranquilizing medications. Usually a psychiatrist with skills in dementia will now be involved with the care of such a person, and they will decide whether medication is appropriate. The most common medication used is something called risperidone. For me as a GP, one of the most valuable medications for somebody with dementia is actually an antidepressant. That's the one thing that I see makes a difference. And that's because, without realising it, a lot of these people have depression, but they don't have the normal symptoms of depression. They can't tell you often the way they're feeling, but actually you can get quite a difference by starting somebody on antidepressants. This is a picture of a church that was a church. This is Little Packington, near to where I live. It's actually been, is decommissioned the right word? Deconsecrated, sorry, yes. But I want you to think about the spiritual side. What's lovely about this church is it overlooks open fields, but it still has the graveyard there. So there's lots of memories there. So let's think about the spiritual side just for a second. Person's spiritual needs will be individual to them and may include questions about meaning, faith and belief. As you will know, as ministers, these need to be possibly addressed, but certainly respected. Personal or religious objects, symbols or rituals, including prayer or readings, may be used. People with dementia usually keep older memories for longer, so they may respond to things they recall from earlier in life, and that's maybe a good example is the hymn that we've just sung. So if you go into a residential home with people with dementia and Songs of Praise comes on the television, you'll often see they start to sing or hum along to the tune, and that's because it's an old memory. That's something that they can, it's familiar to them. This is really key in dementia, is to remember about the informal carer. This is the person that we think about the least. We think about the person that's got dementia, but actually the key person to their care is the person that's with them 24 hours a day, which is often a spouse. It may be occasionally a sister or a brother, but actually you need to be really thinking about that carer. What can we do to support them? Because without them, they can't support the person that's got dementia. So it's very important in relation to spirituality, your role as ministers, to make sure that their spiritual needs are thought about and addressed. And I've used the phrase that they're obviously unpaid, and they're the tip of the iceberg in relation to the problems to do with caring. Dementia is hard. It's one of the hardest afflictions of old age, both for sufferers and their carers. It is a tragedy, and we've said that it's going to become more common. It can steal our words, warp our personalities, and erase our memories. In relation to today, it can test our faith of everybody in this room, as well as the faith of the person with dementia and the people caring for them. It really can. People living with dementia are still able to learn and still able to have something worthwhile to contribute. So it's really important to remember that. You shouldn't write off somebody because they've got dementia, and thinking about what you can actually provide or do for them as a minister. And I know you're going to be talking about that later. Dementia is a grimly stubborn and growing statistic in the unfolding story of our ageing society, and it raises many issues for thoughtful Christian persons. It is important to trust that people living with dementia can still walk with God and be spiritual. Many people living with dementia are still able to read a Bible passage aloud so that they can contribute to worship. So there's no reason why you can't involve them in worship in the church, and one of the things that you could do is to get them to do one of the readings, just as a very simple thing that you could do in an act of worship. I've taken some of this information from the internet. This isn't all my information, but I just picked what I thought seemed important. In fact, I've actually acknowledged where I've got this from. In the real world, suffering is escapable, but suffering isn't the last word about human existence. Life and love are. We live in the hope of resurrection. The ritual of the Eucharist walks us through the cycle of death and rebirth into community with God. That's possibly slightly more relevant to me than some of you in the room, because I know URC tradition, Eucharist isn't with every service, but because I go to an Anglican church, Eucharist is with every service. So that's probably quite poignant for me particularly. It can help provide help the caregiver and the person with dementia alike. So what can we as Christians do? Because obviously everybody here today is here because you are Christians. The best things that we can do are to be present, welcoming and listening. As I've tried to intimate to you, a lot of the skills, and that slide I told you about being a doctor, they're not high tech. They require character, and in relation to what we do as Christians, hold hands, sing songs, listen, care as the best we can. We are the best vicars of Christ who embody the ministry to the lonely and the broken. So you can imagine Jesus would have done what we're talking about in relation to people with dementia. I think in Jesus' time, people didn't live as long as we do now, so that's probably why it's not. Somebody will probably tell me there is a reference in the Gospels to it, but it's certainly not a common thing that Jesus was involved with. I think I've left enough time for questions. I'm very happy to try and answer. I can't promise to answer any questions. I hopefully have given you a little bit of background to the biomedical side of dementia, which will help you with the rest of today. As I say, when I do the workshop later on, I've got some case studies for you. One of them's a real case, which is from my family. The others are what I call typical cases. They're not about real people, but they are about real situations, and they are cases that are going to ask how you as ministers might address particular common situations to do with dementia.
Right. Firstly, Roger, thank you for your presentation and for putting our day into context and giving us medical background as well as sensitive views from yourself. So firstly, can we just thank you for that? Also, hugely impressed that you kept to time. Whenever you invite people to come and speak, some of them do brilliantly, and others you have to get up and say, well, could we have a coffee now, please? And you haven't done that. So that's really great, and we've got 15 minutes for questions that you'd like to put to Roger, and I'll just ask that you speak into the microphone so that everybody can hear whatever questions you've got. Who would like to start off? Lewy
bodies are one of the declines. That's the principal decline for Parkinson's. Is there a relationship between Lewy body, dementia, and Parkinson's?
I was worried somebody was going to ask me that question, so I had to check, because it is very rare. So I've got a slide on Lewy body dementia specifically. Lewy bodies is the second most common type of progressive dementia after Alzheimer's type. Protein deposits called Lewy bodies develop in the nerve cells in the brain regions involved with thinking, memory and movement. So in relation to your question, it may present as Parkinson's disease, particularly if memory problems in the first year, and vice versa. If somebody develops memory problems to begin with and then gets symptoms of Parkinson's, you've got to think that it could be Lewy body dementia. But as my colleague that I shared with this yesterday, all of that has to happen within a period of 12 months. If it's longer than 12 months, it's unlikely to be Lewy body dementia. And I actually have quite a sad story in my own family, that I have a family member who one of my brothers said, it's wonderful news, the consultant says it's Lewy body dementia and they're going to be able to do something, and actually it wasn't. So it's just to make the point, it's a really difficult diagnosis to make, but you're absolutely right, there's this overlap with Parkinson's, but because you've got Parkinson's doesn't mean you've got Lewy body dementia. And I think the thing to think about this is it's incredibly rare. Incredibly rare. I hope that helps. It's a good thing I had that slide, wasn't it? Because I'd have been...
Well, we talked about it ahead of time, so.
Yes, yes. I was worried somebody might ask me about that. Test my medical knowledge.
Are there any other circumstances of life which can leave a person vulnerable to dementia earlier on?
Yes. I said I had patients who died yesterday. Alcohol is actually, can be, because to use the sort of lay phrase, excess alcohol can pickle the brain. So you get people alcoholics who will suffer at a young age with alcoholic type dementia, sometimes called Korsakoff's syndrome. I'm trying to think of other conditions that may be associated. Alcohol is the one that comes to mind. A really specialist area that I don't know the answer to is substance misuse and how that affects brain function. But sadly, there's a multiplicity of substances that people can abuse out there, and there's no doubt that they affect brain function. And actually, thinking about it, I can think of people who have... Some people are more sensitive to cannabis than others, and I can think of people who've abused cannabis, and you'd sort of look at that person and think they've almost like got a form of dementia, particularly if they've gone on to have cannabis psychosis and then become very ill. They're almost like somebody with dementia. So that's a huge, unfortunate growing area, because substance misuse is... I don't know if that answers your question.
I am Peter, I'm the minister in the church in Birmingham, and I help run a lunch club weekly where we have lots of people with dementia. And one of the things I struggle with is lots of people say things to me which I generally know are not the case, and what I struggle with, the right thing to do you bring them back to reality, say actually, you know, that didn't happen, or they believe it really did happen. I never know whether to keep them in their fantasy of that happened or bring them back to reality. I never know which is the correct way to do it. I wonder what you think is the right way. Or is there a right way? I don't know. Thank you.
So that will be one of the questions that I'm going to address with a case... No, don't worry, a case study this afternoon. But first of all, to say there is no right or wrong answer. And you probably have to judge each situation by its circumstance. But I suspect the issue is you don't want to challenge somebody with information if it's going to upset them. Okay. So the classic example is they've forgotten that a loved one has died. That's exactly and do you want to keep challenging them? But you know, your husband died 5 years ago, and then they get very upset. And does one want to keep challenging them with that information? And I think you just have to take each one circumstance in its individual context, and because you'll get to know those people quite well, and you'll know what's the best thing. Or do you just go along with the fact
that's my dilemma? You
know, Jeffrey's at home, and we'll talk about it later with him, and you know Jeffrey's dead, and you know. I think the key thing is not upsetting them, because the problem is some people have got such poor short-term memory that they'll ask you the same question a minute later.
Thank you.
I don't think there's an answer. It's really difficult, but it's so real.
Thank you.
This allows me to walk about. This is good.
Yeah.
Is there a genetic element? I ask because my mum died of vascular dementia, and my younger sister this year died from Alzheimer's. Needless to say, as my memory's poor at the moment.
Yeah. Well, first of all, I don't think we know enough about Alzheimer's to know, because Alzheimer's, remember, is a very... People who have Alzheimer's, we put a lot of people into the category of Alzheimer's. So that's why I say technically you can only diagnose it at post-mortem or with a biopsy. So there may be people who we categorise as having Alzheimer's but have some other type of dementia, and it's not specifically the tissue type of Alzheimer's. So as to whether in your circumstance it's hereditary or not, it's probably unlikely. The bit that is hereditary is people with vascular dementia, but only if they do the things that make vascular disease worse, which is smoking, and lots of other unhealthy things, but specifically smoking. So things like is a form of stroke, basically, cerebrovascular disease. So like people get heart disease, that creates something called atherosclerosis. We're all at risk of that, but some people have a family history of. But if they lead a healthy life and they avoid all the things that they shouldn't be doing, then there's no reason why they should be any more. People with vascular dementia often are people that have not looked after themselves. That's not always the case, but cigarettes are the. You sound I've gone into doctor mode, haven't I? Cigarettes are the. And I've seen it. I've seen it in my own family. I've seen it with my father-in-law, and it's just so sad to watch. And he did that stepwise thing. That you'd see he'd had another bit of his brain would be, a bit of it would gone ischemic, and he went down, and it's really, really difficult. But that's true vascular dementia, but you'll find, yeah, we're all at risk of it, but I think, it's probably to answer your question, it's not going to be hereditary. So, key bit is get out there, walking, avoid the motor car. So all of you are going back on the train, walk to the station, get that blood flow moving through your cerebral arteries.
Roger, come back over here.
I'm going to come back over here. It's good. It's getting my circulation going. You see, that's good.
I'll forgive me the Leicester reference, because I'm a Nottingham graduate.
I am as well.
I met my wife at Nottingham.
Yes.
To turn my friend who suffers from Alzheimer's, he has been living in a dementia care home, and I visited him there and had some very weird conversations, but I just go wherever his butterfly takes him.
Sure.
He then broke his hip in a fall and was taken to Addenbrooke's. I managed to get to see him before his operation, and he was actually quite in an almost vicious frame of mind.
Yes.
Surprisingly physical towards me and some of the nursing staff. I'm glad I had my dementia friend badge to reassure the nursing staff I knew what was going on. I wondered if that was to do with the medication, perhaps the painkillers, whatever that had been applied. And then, subsequent to his repaired hip operation, he's been taken to Fulham, which is psychiatric.
Oh, right, yeah.
And I think they said they were going to take him off all medication and start again, start from scratch. And his wife and I found him transformed, and a lot more of old Harry was there and available. But when I saw him a couple of days ago, he was hallucinating. He wasn't the same Harry. The one-to-one carer didn't really know how to deal with him. Rather than saying, "Sit down, Harry. Sit down, Harry." And I thought, how much variation can there be? And is it necessarily downhill all the way, or can there be, and I don't know under what circumstances, periods of, what would you call it?
Lucidity. Yeah. So, I mean, it's interesting the bit where he became sort of aggressive. So if you imagine somebody who breaks their hip, they'll be in a lot of pain. And also then they're likely to be given opiate type painkillers, which is going to alter their cerebral activity, their thinking. And maybe then he went, after the operation, and then went, as you said, got transferred to this unit. Maybe he went through a period where he was physically more relaxed, and maybe that's why he was more his old self for a little while. But the problem is it is progressive, unfortunately. And it's great that there are specialist units now for dealing with people with dementia, Alzheimer's disease. There are specialist nursing homes, and a lot of the staff there are trained to deal with those scenarios. Not all of them are. I mean, it may be the one that you described hadn't had that training, but it's really, really specialist, and it needs people with a lot of patience and dedication. But there is a move now not to use tranquilizing medication. That's very much frowned upon. And people often come to us as GPs and say, can't you prescribe different tranquilizers? And it's true, we say we're not allowed to, we're not meant to. We have to ask for a psychiatric assessment.
I'm just going to allow one more question.
Sure.
So then after that, please hang on to any other thoughts
Sure.
for the plenary.
Thank you. General anaesthetic, if somebody's already got dementia and they have a general anaesthetic, is that likely to be detrimental to them? And the other thing in hospital, deprivation of liberty, when they enforce them to stay in for a whole week.
Goodness, those are difficult questions. General anaesthetic one's probably easier to answer. I'm sure, hands up who's had a general anaesthetic? And you've probably all felt a bit yuck afterwards, I imagine, because you're filled full of chemicals. But obviously, different general anaesthetics for different conditions and the amount of time that you're asleep for. But I think inevitably any of those chemicals will affect your cerebral function. And the problem with an anaesthetic is it stays in your system for several days afterwards. The half-life of the drugs gradually decays, but some of them stay there for a while, and it depends on what drugs they've given you. So general anaesthetic can certainly affect cerebral function. I think your other question begs all sorts of ethical issues, like, let's say somebody's broken their hip and needs a general anaesthetic to repair it, like the person you've just described.
And Harry had several other operations.
But how do you get informed consent to do that with somebody with dementia? You can't get informed consent. So then in relation to deprivation of liberty and that person having to stay in I think you said for 7 days.
Yeah, they blocked it for 7 days.
Yeah.
It was really weird. And the last couple of days, they were just waiting for blood results.
Yes.
But they would not let her home.
Yeah.
And she was hallucinating.
I know.
And they were physically restraining her, and they weren't trained to deal with dementia.
Yeah. It's something about hospitals I don't understand. I'm not a hospital doctor, but the story you've just told me, I have relatives come and tell me that similar scenario for all sorts of different reasons, not just dementia, time and time again. You know, my mother's ready for discharge, they won't let her go, they say they've got to have something signed or they've got to wait for the medications, and they've sat there for 4 hours and they're still not ready. And as you say, then that person gets upset. And the other interesting bit is if they're a smoker, they want to go and have a cigarette, but the staff won't let them go and have a cigarette, or they want to go and have a drink, and they won't let them go and have a drink, which is a deprivation of their liberty, because that's what they do as if they were at home. And that's the bit that relaxes them, and you know, and then you end up with the scenario you're describing. The problem is that's one of the issues with the NHS, and hence my picture about trams.
Yeah.
It should be guidelines should not be tram lines, they should just be guidelines, and there should be an element of common sense.
Thank you. So if you want to carry on conversations...
Can I just add to that? I think only in nursing.
Yes.
Yeah.
The problem is when you've got somebody who's in hospital, then the medical staff have then got a duty of care. And the problem is if the person forgets that they can't walk, or because you've still got the anaesthetic in your system, the problem is the legalities. Everybody's scared of being sued, and that is the... It feels like they misuse their...
Okay, so if you want to pick that conversation up and carry it on over coffee...
It's a huge conversation, and just to give you an idea that we will teach our medical students in relation to medical ethics, we will have seminar after seminar after seminar are of all those different scenarios. So we're getting our students to think about it, but it's the practical application that's the problem.
Okay. All right. I'm going to make sure you do have your coffee break. So we will we'll come back in at 25 to. So 25 to instead of past, which will give you all time. Please don't forget to. I'll put out the forms for the different workshops. Have a look in your files and sign up. Thank you.